I think I sent another one. It's updates from connective tissue diseases. So when Dr. Abir kindly asked me to present for this talk, she told me to make like a nice, engaging talk. So instead of giving you like a boring outline of the connective tissue diseases, talking about basics and criterias and all of that, I decided to make a talk where we're going to talk about updates about this disorder in a very fun and light way, especially since it's a very late time of the day. So I wanted to be very light, very, let's say, moving in this talk. So, first thing, PCP prophylaxis in patients who take long-term steroids. So, what does that mean? Usually, in dermatology, a large part of what we practice comes from other specialties, especially rheumatology. Like, for example, our regimens for autoimmune blistering diseases as we go for the rheumatology doses. Our cautiousness with medication comes from rheumatology, like, the investigations we do for medications and all of that. We model a lot of part of our practice from the field of rheumatology. And one of the things that we took from them is the PCP prophylaxis. For any patients who has rheumatoid diseases, the American recommendation is that if you take several months of steroids for any indication, you need to protect the patient from getting the PCP pneumonia. And you do that through TMP-SMX prophylaxis. However, just like many other problems, is that we find out that dermatology patients are different from rheumatology patients. For example, with azathioprine, in the past, we used to be very afraid of azathioprine that when we give them long term, they get lymphomas in rheumatoid patients, but it turned out that in dermatology that doesn't happen. Same thing with JAK inhibitors. Like, there are a lot of complications that used to happen in rheumatoid patients that just didn't happen in dermatology patients. One of the things that apparently didn't happen in dermatology patients is PCP pneumonia with oral steroids. So what was the practice where we used to give them TMP-SMX is actually not necessary. And this article that came up a few months ago really changed my practice. I used to give oral steroids for patients, and then accompany it by TMP-SMX. Apparently that is not necessary, and we don't do that anymore. Next, this is for the residents. So can you tell me which one's the misnomer here? You got tumid lupus, lupus paniculatus, discoid lupus, and lupus vulgaris. Which one's the misnomer, you think? So lupus vulgaris, right? Because it's not even lupus, right? So this is a very nice article that came out just a few months ago. I like reading about history, because reading the past teaches you how to move on forward in the future. So the term lupus, in the past, we used to be used for many different entities. But the earliest description for lupus came in the 1700s. It was used to describe an ulcerating condition in the face of patients. So ulcerating entities in the face of patients in the Middle Ages. What was that actually? Cutaneous TB, lupus vulgaris. So the original term lupus was actually for cutaneous TB, which is lupus vulgaris. So that is the one that is actually lupus, and everything else is like a misnomer. Over the years, lupus term has been appropriated for many other entities, like the butterfly rash, the discoid rash, and so we started to move on with the term lupus towards that. So anyways, another study that really caught my attention is this one. It was a large registry that was done for scleroderma in Canada. So they went through all the patients who had scleroderma in Canada and tried to see if there's any variation in terms of geography. It showed that areas that had higher, like more industrial areas, higher air pollution, had higher chances of getting scleroderma. Also, the same study was replicated here. It showed that patients who are exposed to organic solvents or industrial solvents got scleroderma more frequently and more severely. What does that tell me? That pollution or air pollution might have an effect, not only causing cancers, but also can cause connective tissue diseases. That's quite eye-opening for me because, whether we like it or not, we live in one of the areas in the world that is most highly polluted. I mean, personally, I come from Bahrain, and it's always been in the top 10 countries with air pollution. So that might be an eye-opener because this has been happening over the last few decades. Our pollution has been increasing, so maybe that would cause it to change a little bit of policy. Let's have some updates regarding diagnostics for autoimmune diseases. I think I heard you guys had a very wonderful workshop for dermoscopy this morning. Maybe I can add, or like, can you repeat on some of the points? So for lupus, dermoscopy is an indispensable tool for any good dermatologist, I think. And in our region of the world, inflammoscopy, or diagnosis of inflammatory disorders, is more important than neoplastic, because we see more inflammatory disorders than neoplastic. And for lupus, I think for butterfly rash, one of the most important features that is very common in dermoscopy seen in these patients is the reverse butterfly sign. For those who read a lot of dermoscopy, we know that not butterfly, the reverse strawberry sign. So the strawberry sign, which we're used to, is the one in actinic keratosis, where you get red dots surrounded by whitish or white dots surrounded by reddish halos. With lupus, it's actually the opposite. We got the red dots, which reflects follicular inflammation, surrounded by white halos. That's called the reverse strawberry sign, and that's quite different from what we see usually in one of the main mimics of lupus, which is rosacea. With rosacea, you usually get the rhomboidal vessels around a whitish area, so that really helps. Another important dermoscopic feature in lupus comes in discoid lupus. You got your very beautiful keratotic plugs, and also you get your arborizing vessels. See how big this vessel is. Arborizing vessels, we usually associate the term with BCC, but again, over here, at least in my case, I see more lupus patients than BCC patients in my practice. So when you get large areas of arborizing vessels, think of lupus. See how big this blood vessel is. Normally, on dermoscopy, the blood vessel sizes would be as big or smaller than a hair shaft, like you see here. But over here, see, it dwarfs the hair shaft from how big it is. So keep in mind lupus when you see an area with very large arborizing vessels. Another beautiful thing is this. So I always thank my luck for being a dermatopathologist, because it makes me understand things that I normally wouldn't. I always used to think, why does lichen planus present with grayish pigment incontinence or grayish post-inflammatory lesions, and lupus presents with brownish post-inflammatory lesions? Both of them cause pigment incontinence, which means that the pigment is leaking from the epidermis to the dermis. So if both cause pigment incontinence, why does lichen planus look grayish and lupus look brownish? Can anyone answer that? What? It's the same depth. But the difference is the histology. So with lichen planus, what are we used to seeing in the epidermis? Acanthosis. Acanthosis. So there's a thick epidermis between us and the dermis, between our eyes and the dermis. So everything looks grayish because it's deeper. With lupus, especially discoid and there's atrophy. So we're very close to the dermis, so it looks more brownish. So, atrophic lichen planus looks brownish, different from other types of lichen planus. On dermoscopy, atrophic lichen planus actually looks brownish, which again fits into our analysis, which is beautiful. So with dermatomyositis, you expect to see poikiloderma, especially for Gottron sign and papules, because it usually presents with atrophy. So you see beautiful telangiectasia and poikiloderma. And like we saw in the wonderful talk earlier, you got the capillary loops. But remember that dermatomyositis is one of the conditions that, like lupus, produces a lot of mucin. And the nails or the acral areas are part of the areas that get the most mucin, like the face, the ends of the extremities. So sometimes where there's just so much mucin, the area is going to look whitish. So don't let that move you away from the diagnosis of dermatomyositis. It could still be dermatomyositis. There's just a lot of mucin hiding the blood vessels. Okay, this is a nice article that came out around 11 months ago, talking about two FDA-cleared blood tests for systemic sclerosis and lupus. Particularly the one for lupus caught my attention because, when we always say that, ANA is positive in 99% of lupus cases, what about the 1%? What's going to happen? If you get a patient who you really suspect lupus and is negative for ANA, you do the anti-ribosomal P antibody, because these patients are frequently positive for that antibody. And the one for scleroderma is RNA polymerase 3. It's not a really groundbreaking blood test, but to me, it made me aware more that there's a very nice, or remember that there's a very nice diagnostic criteria for scleroderma. So if anyone wants to take a photo of this, this is an important one, because unlike, just like lupus, there is also diagnostic criteria for scleroderma, and you need 9 points to diagnose it, and one of the diagnostic criteria is positive in any of these blood tests, including the most recent one, RNA polymerase 3, so you get 3 points for that diagnosis. Alopecia areata is not a connective tissue disorder. Why am I talking about it today? This nice study that came out just last month involved around 50,000 patients with alopecia areata. It showed that patients with AA have around 2 times likelihood compared to the general population of getting psoriatic arthritis, rheumatoid arthritis, and ankylosing spondylitis. So keep these conditions in mind when you see your patient with alopecia areata. Maybe every now and then, like every year or so, when you follow up your patients, ask them about joint pain, because you don't want to miss any arthritis in these patients. Herpes zoster vaccine, that is very important. Now that we're rolling out a lot of JAK inhibitors, especially with treating connective tissue diseases, we need to know how to deal with the side effects. I mean, I like JAK inhibitors, they're very safe medication, but I think all of you who prescribe JAK inhibitors are aware that these patients get a higher likelihood of herpes zoster. So the American Committee of Immunization Practices recommends that for any patient we want to start the JAK inhibitors, we should give them herpes zoster vaccine before starting the treatment. But if patient is already on treatment and you just remembered, oh no, I didn't start the patient, you can still start the patient the vaccination while on treatment. It's preferable before treatment, but you can definitely give the vaccination while on treatment. So every patient who takes JAK inhibitors should take the herpes zoster vaccine. Okay, so if you haven't been listening to anything I've said so far, well, you're lost, but if you didn't hear anything, this is the most important part of the lecture. So this is a very nice article that came out around 10 months ago. It summarized almost everything that you need to know about the current treatment guidelines, the treatments that are in the pipeline, what works, what doesn't work, and all the major connective tissue diseases in dermatology. I would definitely urge all of you to go through this article. I decided to make a nice summary, or give you the main take-home points from these articles, but I definitely encourage you to read them. So let's start with lupus. By the way, this month is Lupus Awareness Month, so you can start putting on your violet, badges or ribbons or whatever we call them. So with lupus, there's recently 2 FDA-approved treatments. We got belimumab, Benlysta, and anifrolumab. These are the 2 new FDA-approved treatments for these conditions. So first of all, belimumab, it's a monoclonal antibody, inhibits B-cell activating factor, so BAFF. It's used in 2 different ways, either 10 mg per kg every 4 weeks or 200 mg subcutaneous. It has been approved for the treatment of SLE by FDA, but the data, including the data that proved its efficacy, showed in these studies that it's quite effective in treating cutaneous lupus as well. So it's very effective for both systemic lupus and cutaneous lupus. Anifrolumab is a type 1 interferon receptor inhibitor. It's given usually in 1 dose, like 300 mg IV every 4 weeks. It's approved for SLE, and it's likely effective also for CLE based on the study. So it's showing promising results. So the largest study with this has around 559 patients. It shows 62% response rate versus 33% in placebo. And then we got the JAK inhibitors. So due to the huge success, I'm sure everyone here saw case reports and case series showing how the JAK inhibitors work well for lupus, for dermatomyositis. So the popularity of that and the high success of that made some phase 1 trials just now starting to recruitment for multiple JAKs, including tofacitinib and deucravacitinib. And I personally think that these are very promising, and they're going to be very important in our treatment of connective tissue diseases in the coming few years. So what about other JAKs? I think they all will work. Even if we have only studies for tofacitinib, which is the pioneer, other JAK inhibitors also saw some efficacy, like baricitinib, for example, with the dermatomyositis. And why is deucravacitinib very special? Deucravacitinib is the only JAK inhibitor that is not immunosuppressive. So that comes as a very important. All our patients come to us, what about the side effects? What about the side effects? We have to tell them that it's slightly immunocompromising. With this one, it's not immunocompromising. So that's why I think it's a little bit special. Okay, another taking point for lupus is this. So no matter what your regimen is in treating lupus, and I think even other connective tissue diseases, add nicotinamide or niacinamide. It's a vitamin. It's basically harmless. Patients love taking vitamins, and studies show that with any regimen, it has a positive efficacy for these patients. So why not? 5 nmg twice a day. That's it. It's a vitamin. It benefits them in every other way. Okay, Sjogren's syndrome. Just a few updates about Sjogren's syndrome, and that's primary Sjogren's syndrome, where it's not part of lupus or anything, because if it's part of another disorder, you focus on the main disorder. Rituximab has been tried by some studies, not that good. Belimumab, same thing. But for some reason, when you give them both, and the study made a point of that, giving them both is actually effective, both together. Okay. Other promising treatments, like the JAKs, and I talk about the JAKs on the left, not the JAKs on the right. I think anyone who grew up in the 80s and 90s would know these JAKs very well, right, Dr. Abil? Yeah. Okay, so the JAK inhibitors are quite promising also for Sjogren's syndrome. Dermatomyositis. Dermatomyositis, in a nutshell, still, if you want to treat your patient well, you want to give them the best efficacy with the maximum safety, IVIG is still the cornerstone treatment, is still the best treatment for them. Rituximab, not that promising for some reason. Anti-TNFs do not work for dermatomyositis. It has been tried and it has failed. It's not just theoretical. May work. There's ongoing trials as belimumab. Just like it works with lupus, it might work with the dermatomyositis. And what will probably work is, what is this again? JAKs, yes. I think that's the most famous JAK in the world, if I'm not mistaken. Okay, so JAK inhibitors would have promising results, good case reports, good case series, so it will probably work. Okay, and finally, scleroderma. So after you take off your violet ribbons, next month you can put on your, I think, teal-colored ribbons, like light green-colored ribbons for scleroderma next month. So first of all, topicals. Where do you put them for scleroderma? In the garbage. And don't let any company convince you that they have a topical agent that works for scleroderma. Phototherapy in the garbage doesn't work. So what actually works? So for cutaneous sclerosis, what works? MMF is still the first line. You can give higher doses than you usually give for, I usually give 1 to 2 grams for autoimmune blistering diseases. You give higher doses for scleroderma. It's still the first line, and it's not because it's the best treatment, it's because it's one of the safest treatments, and it actually works both for the skin and the lung. Methotrexate has some small studies, but only for the skin. It doesn't usually help with the lung. MMF helps with both the skin and the lung, and I'm talking about fibrosis of the lung. Rituximab also has promising results, and if you add, just like Sjogren, if you add rituximab and belimumab, even more promising results from some studies, and if you even add MMF, well, you get my point, even more benefit, okay? So that's for cutaneous sclerosis. What can also work? Cyclophosphamide might work, but the problem with cyclophosphamide, you can't give it for a very long time due to toxicity, and once you stop the medication, everything comes crashing down. So that's a problem with cyclophosphamide. Stem cell transplantation, hematopoietic stem cell, HSCT. So you need to choose your patient for this indication, because with stem cells you either cure the patient or kill the patient. But it helps with both cutaneous and extracutaneous. So keep that in mind for debilitating cases. And then the JAK inhibitors, again, studies show promising results. But we're very early. There's not much evidence compared to like dermatomyositis and lupus, but some promising results with that. Raynaud's and the ulcers. Lifestyle is very important for the patient, stopping smoking, not exposure to cold temperatures, cold water. They need to dry their skin very often. So that's very important. Like every patient with Raynaud's, you have to tell them like lifestyle advice. And vasodilators, like calcium channel blockers, PDE5 inhibitors, prostanoids are still the first line. And when it comes to severe cases, especially the ulcerating ones, you can give them even as combination. Procedural options, mainly the most evidence so far until now is with the Botox injections and sympathectomy for very severe cases. And that's pretty much it. There's not that much other options that really work for sclerodermas, Raynaud's, and ulcers. Other manifestation, I think that's my last slide. Telangiectasias, they kind of respond well to vascular lasers. Calcinosis cutis, still we don't have any good options. Sodium thiosulfate provides the closest thing to a decent treatment. That's even saying much for it. And for pruritus, Personally, I mean, I see scleroderma patients. Many of them do have a lot of pruritus. I just do the regular pruritus algorithm. I start with like moisturizers and antihistamines. If it doesn't work, I move to SSRIs. If it doesn't work, you move on to things like gabapentin and even like Prigabol and these neurotropic medications, they might work. So you just go through the same algorithm as any idiopathic pruritus for these conditions. So again, thank you very much for holding this event.